Person-centred care is on every strategic plan, but actually making it happen at the coalface, that's where things get tricky. The latest evidence suggests that despite lots of training and quality activity, patient experience is not shifting quickly. So in reality, the gap between what we intend and what actually happens in busy clinics or community settings is still significant. For a long time, the focus and language has been around person-centred care. It's now shifting to person-centred practice for good reasons. Person-centred care generally refers to the model of care used at a system or service level. It's a healthcare approach focusing on an individual's unique needs, values and preferences to ensure they have control and choice over the services they receive. Person-centred practice involves the specific professional competencies that bring person-centredness to life to deliver that care. The term not only includes delivery of care by the workforce, it also relates to treating everyone with respect. That means not only including person-centred principles within interactions with clients, but also interactions between work colleagues and stakeholders. The culture of an organisation, in other words, how things work here, can either significantly promote or stifle the person-centredness of all interactions. We know that person-centred practice does exist. However, unfortunately, it tends to only be in pockets. Global reviews consistently identify the same patterns, and maybe you've seen it. Training that ticks the compliance box but doesn't really impact on practice, or well-meaning protocols that never quite make it off the page or aren't sustained. The truth is, even the most dedicated teams can struggle to turn good intentions into consistent person-centred action, especially when it's such a complex and inherently variable task, and time, resources and competing priorities are at play. 6 factors contribute to this situation. Training in person-centred care is often a one-off event. It can use vague terms and be delivered in isolation, so the workforce is really left uncertain about what to do. Workforce beliefs and attitudes are consistently identified as major barriers. Studies show providers frequently overestimate their own person-centredness. Deeply held traditional care habits are not often recognised or addressed without the right tools. Many organisations use broad implementation frameworks that describe what person-centred care looks like in principle, but not how to do it within a real consultation under time pressure with a complex client. Skills development and practice change doesn't occur without specific feedback. Organisations often lack simple, accessible tools to monitor whether person-centred care is actually happening. While comprehensive measures do exist, they often require specialist expertise and additional funding that most services simply just don't have. Vague definitions and the lack of a shared language to describe person-centred practice create variation and uncertainty. High staff turnover and siloed disciplines mean teams can't sustain practice without a common framework that everyone understands and uses. Finally, many managers are stuck between a rock and a hard place, expected to lead practice change and service improvement, but receiving little operational guidance and often given no dedicated time, budget or tools to do it. So what needs to be done differently? Communicating that person-centred care matters is necessary, but not sufficient. Staff need concrete guidance on what to do, when and how, not just inspiration. Without common terminology across teams, progress doesn't survive staff turnover or team changes. Leaders also need to model the principles in their communication and use the same framework as their teams. You can't manage what you can't see. Simple, accessible feedback tools, not complex audit systems, are what most services actually need. And practice change requires protected time, ongoing reinforcement, and managers or leaders who can coach, not just advocate. This means managers need the same training as their teams. Change requires more than one-off training events. We use the term methodology very deliberately to indicate a bottom-up approach that emphasises how to integrate the theoretical and values-based foundations of a person-centred approach. The content is flexible enough to work at different levels. For the front line, the ultimate aim is to clearly define and make it easier to do the work required and enable teams to work more effectively together. For an organisation, the methodology provides a consistent roadmap for person-centred conversations, workforce competencies, and service design, regardless of setting or social culture. HealthChange Methodology addresses many of the key challenges in 3 ways. It provides the foundational knowledge and tools that support continuous person-centred practice learning across an organisation. Rather than adding another layer of complexity, it gives teams a consistent process for interactions while allowing content to flex to their context. Any learning from existing training can be reinforced and integrated. It builds on what you already have. Skills development is accelerated when learning is embedded into existing structures rather than treated as a separate event. Leaders also gain simple, practical measures to track and target their team's development over time. And critically, HealthChange Methodology doesn't replace the frameworks you're already using. It gives your team the practical tools to make them work at the point of care, and gives leaders the same language and skills to identify service issues, coach staff, and drive service improvement, not just advocate for it. If you're thinking about how to move person-centred care from policy into practice, access our free introduction to the person-centred practice for leaders at healthchange.com.